I am recording it. 1, 2, 3. Antibiotics. From now on, different drugs for different bugs, different drugs for different bugs, different drugs for different bugs, different drugs for different bugs. Okay? So, چرا میشه خاموش کنی؟ ممنون. So, from now on, whatever antibiotics that we're dealing with, we should check. Is it a gram-positive killer? Is it a gram-negative killer? Is it able to kill anaerobes? Is it a staph killer? Is it a Pseudomonas killer? Okay. Gram-positive cocci, a staph and a strep. Whatever kills staph can kill a strep, not the opposite. Whatever kills staph can kill strep, not the opposite. Why? Because the staph has something called penicillinase that can deactivate penicillins. Because it can deactivate penicillins, guys, right? Whatever antibiotics that kill strep cannot kill a staph, but the opposite it does. The staph killers can kill the strep, not the opposite. The strep killers are ampicillin, penicillin, regular penicillins, right? Regular penicillins. But if I want to kill a staph, I have to use specific penicillins who are staph killers. Penicillin is such a great antibiotic, right? Penicillin is such a great antibiotic. Penicillin is such a great antibiotic that pharmaceuticals and pharmacists came up with some adjustment and modifications to enable it to kill a staph. So that's why we have staph killer penicillins. It was so good that they tried to adjust and modify it to enable it to kill gram-negatives like Pseudomonas. That's why we have Pseudomonas killer penicillins. That's why we have staph killer penicillins. What are staph killer penicillins? Ox, clox, diclox, and naf. Dr. Fisher's song. Oxacillin, cloxacillin, dicloxacillin, nafacillin. One more time. Oxacillin, cloxacillin, dicloxacillin, and nafacillin. These are the staph-killing penicillins. These are the staph-killing penicillins. Ox, clox, diclox, naf, oxacillin, cloxacillin, dicloxacillin, and nafacillin. Right? Some of them are IV. Turn my IV on. Oxacillin and nafacillin. Turn my IV on. Oxacillin and nafacillin. Some of them are oral, like cloxacillin and dicloxacillin. These are for methicillin-sensitive Staph aureus. If I have a sensitive staph, I can give them ox, clox, diclox, and naf. But you know what? Some staphs are methicillin resistant, so they are MRSA. There is a reason that Vanco came into the market to kill methicillin resistant Staph aureus. So from now on, strep killers, regular penicillin, penicillin, ampicillin, amoxicillin, these are regular strep killers. But another gram-positive coccus, which is a staph, the Staphylococcus, needs some extra attention because the staph types usually have something called penicillinase that can deactivate. They can deactivate regular penicillins. So we have to modify and adjust penicillins in order to enable them to kill the staph. That's why we have staph-killing penicillins, oxacillin, cloxacillin, dicloxacillin, nafacillin. Some of them are IV. Turn my IV on. Oxa and naf is IV. Cloxacillin and dicloxacillin are PO. In case I have MRSA, I have Vanco. In case I have MRSA, I have Vanco, vancomycin for killing MRSA. Vancomycin for killing MRSA. Okay? So we have methicillin-sensitive Staph aureus, we have methicillin-resistant Staph aureus. Methicillin-sensitive Staph aureus, oxacillin, cloxacillin, dicloxacillin, and NAF, and methicillin-resistant Staph aureus, MRSA, vancomycin. Clear, guys? Clear? So we are done with this side of the spectrum. We are done with this side of the spectrum. Okay? We are done with this side of the spectrum. Now, we are coming to the other side. Gram-negative cocci, gram-negative diplococcus, because they are usually 2 by 2 together. Gram-negative diplococcus, gram-negative cocci, gram-negative coccus is Neisseria family. Gram-negative diplococcus are Neisseria family, meningococcus and gonococcus. Meningo and gono, right? Meningitis and gonorrhea. Meningitis and gonorrhea. What do we give them? Ceftriaxone. Actually, meningitis with Neisseria, ceftriaxone. Gonorrhea with Neisseria gonorrhea, ceftriaxone. Right? So third generation cephalosporins can kill gram-negative cocci, right? Okay. What about gram-negative rods? Gram-negative bacilli. Gram-negative bacilli are E. coli and its cousins, Enterobacteriaceae family. Enterobacteriaceae family. E. coli, Klebsiella, Pseudomonas, Serratia, Enterobacter. These are gram-negative rods. Gram-negative rods are nasty infections. If you want to pick up a nasty gram-positive, pick up staph. If you want to pick up a nasty gram-negative, Pseudomonas. So it is important that this antibiotic can kill gram-positives, can kill gram-negatives, can kill the nasty gram-positive staph, can kill the nasty gram-negative Pseudomonas, or not. So E. coli and its cousins, keeps, right? Keeps, Klebsiella, Enterobacter, Pseudomonas, Serratia, E. coli, right? These are gram-negative rods, Enterobacteriaceae family, E. coli and its cousins, right? E. coli and its cousins, especially Pseudomonas, are such terrible germs that it can give me TIA, transient ischemic attack. It's such a nasty, they are such nasty germs that it can give me TIA. I get scared when I see them, right? I get scared when I see them. So it might give me TIA. Ticarcillin, imipenem, astronome, ticarcillin. These guys will be short guys, no worries. Ticarcillin, imipenem, astronome, ticarcillin, imipenem, astronome, ticarcillin, imipenem, astronome, TIA, right? Guys, what is ticarcillin? Ticarcillin, carbapenicillin, piperacillin. These are Pseudomonas killing penicillins. Penicillin is a broad spectrum antibiotic. It can kill a lot of gram-positives. It can kill a lot of gram-negatives, but it's not so great on the nasty gram-positive staph. It's not so great on the nasty gram-negative Pseudomonas. But it was such a great antibiotic and saved so many lives that pharmaceuticals came up with some adjustments and modifications on it to enable it to kill the nasty gram-positive staph. That's why we have the staph-killing penicillins like oxacillin, cloxacillin, decloxacillin, nafacillin, ox, clox, declox, and naf, ox, clox, declox, and naf, ox, clox, declox, and naf, oxacillin, cloxacillin, decloxacillin, and nafacillin. They can kill regular staph, sensitive staph, regular staph, sensitive staph, regular staph, sensitive staph, right? Which is not resistant, which is methicillin-sensitive Staph aureus. Ox and the rest of the ox and clox and declox and naf here. But if I have MRSA, methicillin-resistant Staph aureus, we give the patient vancomycin. Every single time that you hear Vanco, remember MRSA. Every single time you hear MRSA, remember Vanco. Vanco connected with MRSA, MRSA connected with Vanco. Can you repeat the roots of MSSA? Ox, clox, declox, and naph, right? Oxacillin, cloxacillin, decloxacillin, naphacillin, right? Guys, it will be repeated in the book as well, right? Turn my IV on. Which ones are IV? Oxacillin and naphacillin are IV, right? So if I need to kill a staph, serious infections with IV antibiotics, that would be oxacillin and naphacillin. Cloxacillin and decloxacillin are PO, okay? So penicillin was such a great antibiotic that pharmaceutical says, you know what, let's modify it and make a staph-killing penicillins. Oxacillin, cloxacillin, decloxacillin, naphacillin. Can it kill regular staph? Yes, it can, sensitive staph, but it cannot kill MRSA. It cannot kill resistant staph. That's why for resistant staph or MRSA, we have specific antibiotics like vancomycin and some other antibiotics like linezolid, like daptomycin, like quinopristine. Quinopristine was in pharmacology books. It's a while that I haven't seen it in the textbooks. It means internal medicine, for example. But quinopristine was a specific quinolone. Quinopristine was a specific quinolone to kill MRSA. Linezolid, daptomycin, and some other cousins of vancomycin are for MRSA that we'll talk about them. But remember for now, MRSA, Vanco, Vanco, MRSA. Okay? Also, penicillin was such a great antibiotic. Broader spectrum, kills a lot of gram-positives, kills a lot of gram-negatives, but it was not able to kill nasty gram-positives like Pseudomonas. Sorry, nasty gram-negatives like Pseudomonas. It was not able to kill nasty gram-negatives like Pseudomonas. So they modified and made Pseudomonas-killing penicillins. Piperacillin, ticarcillin, carpenicillin, piperacillin, ticarcillin, carpenicillin, piperacillin, ticarcillin, carpenicillin, piperacillin, ticarcillin, carpenicillin. And these are Pseudomonas-killing penicillins. Anything else that can kill Pseudomonas? Sure, TIA, gram-negative killers, gram-negative bacilli killers, the same germs that gives me TIA, ticarcillin, or imipenem, or astronome. We'll talk about imipenem, astronome, and ticarcillin in a couple of minutes. A question for you. Among ticarcillin, imipenem, astronome, which one is beta-lactam? Which one is beta-lactam antibiotic? Among ticarcillin, imipenem, astronome, which one is a beta-lactam? Only imipenem? Only imipenem? Astronome is not monobactam? Ticarcillin is not a specific penicillin? Ticarcillin is not a specific penicillin? Astronome is monobactam. That might have some cross-antigenic reaction with beta-lactams. I do agree. What about ticarcillin? Ticarcillin is not penicillin? Ticarcillin is not penicillin. It is. So almost all of them are beta-lactams. Astronome with a little bit discount because astronome is monobactam, but it has cross-antigenic reaction. Ticarcillin is anti-pseudomonas-penicillin, right? So they're beta-lactams. Beta-lactams. We'll talk about it in a second. We'll talk about PICA antibiotics. We'll talk about PICA antibiotics. No worries. We'll talk about PICA antibiotics, right? Guys, gram-positive bacilli. What is gram-positive bacilli? Listeria. Gram-positive bacilli or gram-positive rod is listeria, right? Sometimes in the even Canadian exams, they will not tell you, for example, the staph or strep. They will tell you gram-positive cocci. Sometimes they will not tell you, for example, E. coli and its cousins. They will tell you gram-negative rod or gram-negative bacilli. They will not tell you gram-negative cocci. They will tell you gram-negative. They will not tell you Neisseria sometimes. They will tell you gram-negative Diplococcus in the CSF culture, for example, or in the CSF gram staining. Gram-positive bacilli or gram-positive rod is Listeria. Listeria, diphtheroid in the CSF, for example. Oops, diphtheroid? Is it diphtheria? No, it's diphtheroid. Diphtheroid looks like diphtheria, but it's not diphtheria. It's diphtheroid in the CSF. Diphtheroid in the CSF or gram-positive bacilli in the CSF is Listeria. In which patients? Young patients, old patients, immunodeficient patients, kids, newborn babies, elder patients, immunodeficient patients, right? Amino of neurology was saying less than 3 months, extremities of age, less than 3 months and over 50 years of age. Some other books might tell you less than 1 month and more than 60 years of age. Early childhood, elder patients, and immunodeficient patients, HIV positive patients, are at risk of Listeria meningitis. So what do I add to my meningitis cocktail in immunodeficient, HIV positive, extremities of age patients? Ampicillin, 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 right? Ampicillin. Why? Because meningitis cocktail is ceftriaxone, vancomycin, is ceftazidime, vancomycin, ceftriaxone, vancomycin, ceftazidime, vancomycin, empiric treatment of meningitis. And in extremities of age or immunodeficient patients, less than 3 months, more than 50 years, or less than 1 month, more than 60 years, different books are different. Immunodeficient HIV positive patients, ampicillin should be added to the cocktail. Ampicillin should be added to the cocktail. Is this slide clear for everybody? Dr. Wonwa, are you here? Okay. Other docs, is that clear? Ampicillin. I didn't say amoxi. I said ampi. I didn't say amoxi. I said ampi. For Listeria. 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 Pseudomonas killing penicillins, piperacillin, ticarcillin, carbonicillin, piperacillin, piperacillin, ticarcillin, carbonicillin. These are Pseudomonas killing penicillins. Oh, sorry. Pennies. Pennies. Penicillins, I meant. Penicillins, I meant. Piperacillin, ticarcillin, carbonicillin, piperacillin, ticarcillin, carbonicillin. These are Pseudomonas killing pennies, means penicillins. Dr. May, we will add ampicillin to kill Listeria for extremities of age less than 1 month or more than 60 years, less than 3 months or more than 50 years. Amino of neurology was saying less than 3 months, more than 50 years. Some other books might say less than 1 month, more than 60 years. Extremities of age, I will add ampicillin to my cocktail, meningitis cocktail, to cover Listeria. Also, immunodeficient patients, HIV positive patients. Everybody clear? Everybody clear, guys? Any questions so far? The speed is okay? We are trying to be as efficient as possible now that there's been so much time. Oh, Dr. Bianca is here. Oops. From now on, every single time that sexy girls are coming to your office, to your office, guys, and handsome guys are coming to your office, ladies, right, as drug reps, and they want to sell you something, you want to show them that you know something more than them, right? Because they do 3 months of biology and pharmacology and these kind of stuff, and 3 months of marketing and sales, and they come to your office and they want to sell you stuff. Sometimes they want to sell you shit, right? You want to show them that you know better than them, right? You want to show them that you know better than them, right? You want to show them that you're better than them, right? So every single antibiotic that they put in front of us, every single antibiotic that we're discussing, it's important to know, can it kill gram-positive? Can it kill gram-negative? Can it kill anaerobes? And if it is able to kill gram-positives, is it able to kill nasty gram-positive staph? Is it able to kill nasty gram-negative Pseudomonas? So from now on, whatever antibiotic I have in front of my eyes, I will think, is it a gram-positive killer? Is it a gram-negative killer? Is it an anaerobe killer? The gram-positive coverage, is it able to kill a staph, nasty gram-positive? Is it able to kill nasty gram-negative Pseudomonas? That's the approach for every single antibiotic or every single antibiotic family that we study, right? Guys, it's not, oh, vancomycin is better than penicillin or quinolone is better than erythromycin. It depends. What do you want to kill? Different drugs for different bugs, right? Different drugs for different bugs. I am recording the antibiotics for you guys as my penalty. So penicillin, right? Penicillin is a gram-positive killer, is a gram-negative killer. To some extent, it can kill, it's not a fantastic anaerobe killer for sure, but it's a broad spectrum antibiotic. It can kill a lot of gram-positives. It can kill a lot of gram-negatives, can kill a lot of gram-positive, can kill a lot of gram-negatives. That's why we call it broad spectrum. Anaerobes, maybe to some extent. But is it able to kill staph, nasty gram-positive? No. Because the staph has something called penicillinase. So regular penicillin is not so good on it. It gets deactivated. Penicillinase is an enzyme that breaks down penicillin. So it can deactivate penicillin. So penicillin cannot kill staph, nasty gram-positive. What about Pseudomonas? Is it able to kill gram-negatives? Yes, it can. What about nasty gram-negative like Pseudomonas? No, not the regular penicillin. Can I boost penicillin to kill a staph? Sure. Oxa, Cloxa, Dicloxa, Naf, oxacillin, cloxacillin, dicloxacillin, nafacillin. Now you have a staph killing penicillin. Can I boost penicillin? Mototarbiyat. Can I boost penicillin to kill Pseudomonas? Sure. Piperacillin, ticarcillin, carbonicillin, piperacillin, ticarcillin, carbonicillin, piperacillin, ticarcillin, carbonicillin. All right? These are Pseudomonas killing penicillins. Okay? Clear with penicillin, guys? Are we clear with penicillin? Amoxi-ampi, other penicillins. Amoxi and ampi. Amoxi and ampi, yes, good coverage on gram-positive. Yes, good coverage on gram-negative. Sure, they can kill a strep for sure. They can kill a strep for sure. Penicillin can kill a strep for sure. Amoxi-ampi can kill strep for sure, but not a staph. But not a staph. That's why, guys, ENT germs. Shimo. ENT germs are shimo, a strep, pneumonia, a strep, pneumo, Haemophilus, influenza, Moraxella catarrhalis. These are ENT germs. These are ENT germs. Sinusitis, otitis, pharyngitis, upper respiratory tract infection. Sinusitis, otitis, pharyngitis, upper respiratory tract infection. How do you treat these patients? Amoxi. After a couple of days, still my patient is not getting better. Amoxiclav. Put a helmet on the amoxi. Put a helmet on the amoxi. After a couple of days, it's still not working. Put a helmet on your regular amoxi and turn it to amoxiclav, augmentin, to augmentate the effect of amoxicillin. Oh, interesting. So ENT germs can be easily killed by amoxi. After a couple of days, not getting better, amoxiclav. Boost your amoxi with amoxiclav. All right? So, is it a good gram-positive killer? Sure. Is it a good gram-negative killer? Sure. It's a penicillin antibiotic. Amox and Ampere penicillins, right? Regular penicillin, so they're a broader spectrum. But are they able to kill a staph? No. The staph has penicillinase, deactivates it. What about gram-negatives? Pseudomonas? No. What about anaerobes? Maybe. It's not the best anaerobe killer, but maybe. This is the regular penicillins. Are we clear? Good. Oops. Let's talk about cephalosporins. Let's talk about cephalosporins. Let's talk about cephalosporins, right? Let's talk about cephalosporins, right? Let's talk about cephalosporins. Cephalosporins have first generation, second generation, third generation, fourth and fifth, and these kind of stuff. Cephalosporins are broad spectrum antibiotics. We have from first generation all the way to the fourth and fifth generation. We have first generation as cephalexin. We have second generation as cefuroxim. We have third generation as ceftazidime, ceftriaxone. We have fourth generation as cefepime, for example, right? So these are cephalosporins. Cephalosporins are broad spectrum antibiotics. Broad spectrum antibiotics, right? This side was gram-positive, remember? This side was gram-negative, remember? This side was gram-positive. This side was gram-negative. Gram-positive, gram-negative. Cephalosporins are broad spectrum antibiotics. We have first generation, second generation, third generation, fourth generation, fifth generation. First generation, cephalexin. Second generation, cefuroxim. Third generation, ceftazidime, ceftriaxone. Fourth generation, cefepime, for example. Do we have oral third generation? Oral third generation? That you can easily use it for even UTI. Oral third generation, guys. What is it? What is the name? Oral third generation. Cefexim, Zenat. That's a very brand name. I'm not aware of it. I know. Cefexim. Cefixim. No, I didn't know the brand name. I have never heard that brand name. Cefixim, right, is third generation. Cefodoxim as well. Cefodoxim as well. Third generation. Third gen PO. Cephalosporin. Like cefixim, right? Cefixim, for example, third generation oral. So cephalexin, cefuroxim, ceftazidime, ceftriaxone. Dr. Johnny, I think you actually joined online a little bit late. Dr. Hamid sent me an article from Medscape about whole blood in the wars and in the frontiers. Warm, fresh, whole blood for patients that need massive transfusion. But it's written that it's not being used for civilian use or something like that in that Medscape article. If I'm not mistaken, Dr. Hamid, correct me if I'm wrong. So basically, but I haven't seen it in the exams as whole blood or something like that for GI bleeding or trauma. But in the frontiers or in the wars or something like that, that can be something in war medicine, they might use it. And it can be a correct answer, but I think that's a little bit too much for our exam level. So cephalosporins, broad spectrum antibiotics in general, from first generation to fourth generation: cephalexin, cefuroxime, ceftazidime, ceftriaxone, cefixime, cefepime. What is happening from first to the third generation? From first to the third generation, no problem, Jenny. From first to the third generation, Dr. Hamid can share it to the group as well. I will appreciate, actually, to the GI group, what he sent me. So basically, cephalexin, cefuroxime, ceftazidime, ceftriaxone, cefixime, and these kind of stuff, right? From first generation to third generation, although they are broad spectrum, but from first to third, something is happening. The coverage on gram negatives are getting better by the expense of losing a little bit of gram positive coverage. One more time. From first to third generation, I am increasing the gram negative coverage by the expense of losing a little bit of gram positive coverage. Does it mean that cephalosporins, for example, second generation, third generation, are not gram positive killers? No, it doesn't mean like that, because they're broad spectrum. But comparing first to the third generation, I am losing a bit of my gram positive coverage and I'm increasing to my gram negative coverage. Also, this is meninges. It's important to remember that, for example, second generation cefuroxime comes and kisses my meninges, but ceftazidime, ceftriaxone comes and penetrates my meninges. So good meningeal penetration for meningitis. That's why ceftazidime, ceftriaxone plus vancomycin is empiric antibiotic therapy for meningitis. With vanco, I am covering gram positives, mainly MRSA. With ceftazidime, ceftriaxone, I am covering gram negatives. Extremities of age and immunodeficient patients, HIV positive patients, I will add ampicillin to my cocktail to cover listeria as well. What is listeria? Listeria is a gram positive bacilli, diphtheroid in my CSF, gram positive rod in my CSF. So from first to third generation, I am losing a bit of my gram positive coverage, not fully, but a little bit, and I'm increasing its coverage on gram negatives. Also, first generation is not a good. Have you ever seen any doctor prescribing cephalexin for meningitis? I have seen, but the patient ended up dead. The patient ended up dead, by the way. ENT. after rhinoplasty, and the patient after rhinoplasty and the cephalexin, I don't think so. Cephalexin? No, it was not US actually. I will not reveal the name of the country, right? So yeah, after rhino, the patient has a little bit of leakage, right? CSF leakage, then a little bit of symptoms of fever, right? Fever and these kind of stuff. It was not, I'm not sure it was rhino or sinus or something like that, but the patient has some CSF leakage. And then the patient started having fever or something like that. Young patient, right? Young patient. Cephalexin? Are you kidding me? Cephalexin for meningitis? That's very, actually nasty choice. That's very nasty choice, right? Because it doesn't get into the meninges. You wanted to cover what? Meningitis with cephalexin? So it doesn't have a good coverage on meninges. It doesn't even penetrate. Cefuroxime comes to the meninges and gives it a kiss only. But ceftazidime, ceftriaxone has getting penetrating into the meninges, and it's good for the treatment of meningitis. Cefepime is quite broad spectrum, covering good gram-positive coverage, good gram-negative coverage, and to some extent, it can cover anaerobes as well, to some extent. We have fifth generation and this kind of stuff, too much for our exam. Too much for our exam. Everybody is clear with cephalosporins, guys? Cephalosporins clear. Cephalosporins 3, cephalosporins 2, cephalosporins 1, and we are moving on. PICA antibiotics. PICA antibiotics. Dr. May, let's forget about it. Let's forget about it. Let's forget about it. I was waiting for that question. I was waiting for that question. We have better choices for anaerobes. For sure, we have better choices for anaerobes, right? So it's better not to argue with an intensivist. It's better not to argue with an intensivist. What about your books? What about your books in actually intensive care? Do you use cefepime for anaerobes? Do you use cefepime for anaerobes? Because these are the things that only infectious disease specialists, internists, and intensivists use it. Okay, so then forget about it. Then forget about it. So forget about cefepime for anaerobes. Guys, we have intensivists on board, we have internists on board. So they say no, they don't use it for anaerobes. Let's not use it for anaerobes. Let's not use it for anaerobes. PICA antibiotics. PICA antibiotics, guys, it's a mnemonic to remember. The beta-lactams. Why does it matter? Because they have cross-allergic reaction. They have cross-allergic reaction with each other, right? If you're not an infectious disease specialist, if you're not an internist, if you're not an intensivist, probably you have never used imipenem astronome, most probably. You might have witnessed other doctors use it, but probably you have never prescribed it, imipenem or astronome, right? But penicillin, cephalosporins, all of us prescribed it, right? Penicillin, cephalosporins, P, penicillin, C, cephalosporin. Any other beta-lactam antibiotics? Yes, imipenem and astronome. I put astronome in parentheses to remember that astronome is monobactam, it's a single ring, but it can have cross-allergic reaction with the rest of the beta-lactams. Beta-lactam antibiotics, or with a little discount, beta-lactams plus monobactam antibiotics are PICA, PICA, penicillin, imipenem, cephalosporins, astronome. Are we clear? Are we clear, guys? Okay. Guys, imipenem meningitis in HIV patients. It's being used. It's being used. Dr. Johnny, what is your specialty? It seems that you work on a lot of HIV patients, I guess, right? You work with a lot of HIV patients, I guess, right? Because I remember some other stories that you were telling us. So mild allergy, general practitioner, but did you actually work with a lot of HIV positive patients? Was it you or somebody else? Okay, so I remember, my memory is still intact. Mild allergy and severe allergy. Mild allergy and severe allergy. Guys, what is mild allergy? Rash only. What is mild allergy? Rash only. What is severe allergy? Anaphylaxis, right? If I have mild allergy to penicillins, penicillin brothers, any of them, can I marry their cousins, cephalosporins? Yes, I can. So if it is mild allergy, rash only to penicillins, I can still marry their cousins, cephalosporins, but I will not marry the brothers. I will forget about the penicillins, but I can still marry their cousins, cephalosporins. Rash only, mild allergy. Okay? It's less than 1% cross-allergic reaction. In reality, it's even lower. But if it is severe allergy, anaphylaxis to penicillins, I will not marry penicillin brothers. I will not marry cephalosporins, their cousins either. I should find another girl or another guy from another town, another tribe. Forget about the whole family. Severe allergy, anaphylaxis to any of the penicillins, I will not marry the penicillins. I will not marry the cephalosporins. I will not use penicillins. I will not use cephalosporins. I will not probably use any of the other beta-lactams. Why? My patient might die next time. Mild allergy, rash only to penicillins, Can I still use cephalosporins? Yes, I can. Will I use penicillins? No, not anymore. My patient has mild allergy rash to penicillins. I will not give them penicillins, but I can give them cephalosporins. The sketch is clear for everybody because we are moving on. PICA is safe in pregnancy. Absolutely. Dr. Nasrin is saying PICA or beta-lactam antibiotics are safe in pregnancy beside acyclovir, beside azithromycin. Absolutely correct. PICA antibiotics or beta-lactam antibiotics are safe in pregnancy beside acyclovir, beside azithromycin. Metronidazole is quite safe as well. Penicillin. Oops. Now, time to talk about three actually categories of antibiotics that are very similar to each other in terms of their coverage. Now, time to talk about three different categories of antibiotics that somehow very similar coverage. Erythro, TMPSMX, and Cipro. We picked up erythro as a prototype of a macrolide. We picked up TMPSMX as a prototype of a sulfa drug. And we picked up Cipro as a prototype of quinolones. So macrolides like erythromycin, clarithromycin, azithromycin. Macrolides like erythromycin, clarithromycin, azithromycin. Sulfa drugs like TMPSMX, cotrimoxazole, cooperation of trimethoprim, sulfamethoxazole. What being known in North America as TMPSMX, trimethoprim, sulfamethoxazole. What's being known in the Middle East as cotrimoxazole, cooperation of trimethoprim, sulfamethoxazole, right? Is a sulfa drug. And quinolones like Cipro, or other fluoxetine. We picked up these guys as prototypes, that's it, of each category. Gram-positive coverage, yes. Gram-negative coverage, yes. Gram-positive coverage, yes. Gram-negative coverage, yes. Gram-positive coverage, yes. Gram-negative coverage, yes. What about nasty gram-positive staph? Maybe. What about nasty gram-negative pseudomonas? Maybe. What is the weak point? Not covering anaerobes. What is the weak point? Not covering anaerobes. That's the weak point. Not covering anaerobes. That is the hint. That is the tip. Right? So erythromycin, clarithromycin, azithromycin, TMPSMX, and quinolones. Good gram-positive coverage. Good gram-negative coverage. What about the staph? Nasty gram-positive? Maybe. What about nasty gram-negative pseudomonas? Maybe. What is your weak point? You're not covering anaerobes. Okay. One more thing. We never use penicillin for empiric management of meningitis. It's not enough. One more time. Penicillin is a fantastic antibiotic. It saved a lot of people's lives. From pneumonia to syphilis to a lot of things. Before penicillin, a lot of patients were dying because of infections that they never die these days because of those actually infections. Penicillin was a revolution in medicine. That's why Fleming got the Nobel Prize for it, right? He got the Nobel Prize for it. It saved so many lives. It was a revolution in medicine, right? So this was a random finding, but it was fantastic. So, but penicillin is never enough for empiric management of meningitis. Another one, we never use Cipro for the management of CAP, community-acquired pneumonia. We never use Cipro for the management of CAP, community-acquired pneumonia. Why? Cipro is a fantastic antibiotic. It's a broad spectrum antibiotic. But Cipro weak point is pneumococcus, a streptococcus pneumo. The strep pneumo or pneumococcus is the weak point of ciprofloxacin. Oh, what is the most common cause of CAP? Pneumococcus, the streptococcus pneumonia. So Cipro is not killing pneumococcus. So we never use Cipro for pneumonia. We never use Cipro for pneumonia. What about other quinolones? Absolutely, we use it. What about other quinolones? Absolutely. They are so good for pneumonia that we even call them pulmonary quinolones, like moxifloxacin, levofloxacin, gatifloxacin, whatever floxacin, but Cipro. They are so good in their pulmonary penetration and killing pneumococcus and pneumonia that we call them pulmonary quinolones. But Cipro, interestingly, can kill Pseudomonas. Cipro is not able to kill pneumococcus, but Cipro can kill Pseudomonas. That's why you might see it in patients with cystic fibrosis, that Pseudomonas can be colonized in their airways. So we keep Cipro for pulmonary infections in cystic fibrosis patients, maybe as basically rotational antibiotics that we use for them. One of them can be Cipro. You just told us do not use Cipro for pneumonia. Yes, I said that. I'm still saying that. By pneumonia, I mean CAP, community-acquired pneumonia. Is there any situation that you might use Cipro for pulmonary infections? Yes, in Pseudomonas pulmonary infections, in cystic fibrosis patients, because we try to rotate from this antibiotic to another antibiotic to another antibiotic, so the patient doesn't develop resistance. Cipro can be used because Cipro, weak point, is pneumococcus, but interestingly, Cipro can kill Pseudomonas. Are we clear? Clear, guys? Any question? Any comment, any question, any hint, any tip? Okay. So, what about clindamycin? PICA is safe in pregnancy beside acyclovir. Yes, beside azithromycin. Beside azithromycin as well. Azithromycin as well. Metronidazole is quite safe as well. Nitrofurantoin can be used as well. We'll talk about them. We'll talk about them. Clinda is a good gram-positive coverage. Can it kill staph? Yes, it can. Yes, it can. Also, it's a fantastic anaerobe killer. It's a fantastic anaerobe killer as well. Clindamycin, right? Clindamycin is a fantastic anaerobe killer as well, especially anaerobes above diaphragm. Especially anaerobes above diaphragm. For example, ENT abscesses, right? For example, actually dental abscesses. For example, pulmonary abscesses. Clindamycin is a very good, also it has a good bone penetration, right? Bone penetration. For example, the patient has sinusitis and tenderness on the bone. Clindamycin has good, actually, bone penetration as well. For example, sinusitis involving the bone as well. My generation, remember Pott's puffy tumor or something like that, which is osteomyelitis of the frontal bone. If you have frontal sinusitis, the infection might get into the bone as well, right? So the patient has bone tenderness on the tap as well. Clindamycin has a good coverage on those kind of situations. It has a good actually bone penetration. I'm quoting ENTs, by the way. So staph can be covered. Yes, good. Gram-positive coverage, especially staph can be covered. Clindamycin is a beautiful anaerobe killer. Is a fantastic anaerobe killer, to the point that we say anaerobes above diaphragm, clindamycin, anaerobes below diaphragm, metronidazole, flagyl, anaerobes above diaphragm, clindamycin, anaerobes below diaphragm, metronidazole, flagyl. It's being used interchangeably as well. It's being used interchangeably as well. Good. That's the story of clindamycin. That is the story of clindamycin. Pulmonary, Dr. Hadami. Pulmonary. Lung abscess. Lung abscess. Lung abscess. The patient will be on a couple of weeks of clindamycin. Sinuses as well. It has a good bone penetration if the bone is involved. Clinda is for abscesses, anaerobes above diaphragm, right? Clinda is for abscesses above diaphragm, anaerobes above diaphragm. So for example, dental abscesses. A lot of my dentist friends still actually prescribe metronidazole for dental abscesses, but Clinda is better. But Clinda is better, right? Clinda is, in general, is a good anaerobe killer, especially above diaphragm, like dental abscesses, lung abscesses, dental abscesses, lung abscesses, right? The patient might actually get over a lung abscess with a couple of weeks of antibiotics, clindamycin, for example. And it might actually, you might spare the patient from getting any drainage of that abscess in the lung, right? So lung abscesses can be treated medically only. And maybe amoeboic liver abscess can be treated medically only. Metronidazole, for example, right? So where is the liver? Under the diaphragm, I have amoeboic abscess. Abscess, what am I using? Metronidazole. Lung abscess, where is the lung? Above diaphragm. Clindamycin might be a better choice. But they are being used interchangeably as well. Good, guys? Good. Okay. Moving forward. Neutropenia, guys. Dental clinic can be used as well. Dental clinic can be used as well. Dental clinic can be used as well. I have seen my dentist friends still using flagyl metronidazole for it, though. I still see a lot of my dentist friends that still use metronidazole for dental abscesses. Clinda might be better even. So, ladies, gentlemen, doctors, first layers of defense in the body. First layers of defense in the body. Amoxiclov. Amoxi for dental abscess. Amoxi alone might not be a fantastic choice. Amoxiclov is better, right? Amoxiclov is better than amoxicillin alone for a dental abscess, maybe. Neutropenia, ladies and gentlemen, the first layer of defense, of the body, the spleen and neutrophils. Patients without a spleen are at risk of sepsis with capsulated organisms, especially pneumococcus and Haemophilus influenza. Right? That's why we vaccinate them. Patients with traumatic splenectomy or functional splenectomy, patients with sickle cell, after a couple of years, they get micro infarcts in their spleen, and their spleen shrinks. So it's autosplenectomy. Patients without a spleen, functional autosplenectomy or surgical splenectomy, traumatic splenectomy, no spleen, you are at risk of capsulated germs, especially pneumococcus and Haemophilus. No spleen. Neutropenia is another, neutrophils are another layer, another first layer of defense in the body. So if you have neutropenia, then I will take every single sign of infection in you very seriously. What is neutropenia? The official definition of neutropenia is ANC count less than 1,500. ANC, absolute neutrophil count. Absolute neutrophil count, right? Usually 55, 60, 65% of my white PCs are neutrophils, PMNs, polymorphonuclears, right? So neutropenic patients, we always take it seriously. For example, the patient is on chemo and the patient neuts are going below 1,500. They give them a rest on chemo. Sometimes they give them GCSF, actually subcutaneous injections to increase their neutr count to restart their chemo. Why? All neutrophils are one of the first layers of defense against germs. So if I have neutropenia, I'm at risk of sepsis. We always take neutropenia and fever seriously, right? We don't send the patient with neutropenia and fever home and say, oh, that's okay, it's okay. It's a different story. If I'm 38.5 and I'm healthy and normal, right, you might send me home with even oral antibiotics or something like that. Depends on the scenario. But you check my temperature is 38.4 and my CBC is showing that my neutrophils are, for example, 1,200, I will always take it seriously. I will always do extra workup for those patients. Those patients can easily get into sepsis and die, right? What is severe neutropenia? Absolute neutrophil count less than 500. If my absolute neutrophil count goes below 500, that's severe neutropenia. That I'm at risk of nasty germs, like staph infections, like Pseudomonas infections, like Enterobacters, like Aspergillosis. Neutropenia is a dangerous situation. Severe neutropenia is double, triple dangerous. What is severe neutropenia? Absolute neutrophil count less than 500. Why? Nasty germs comes into the picture, like nasty gram-positive staph, like nasty gram-negative Pseudomonas, like another gram-negative Enterobacters, like fungus, Aspergillosis. These are nasty germs. For Persians, اسپ مونا انتر است 500 تومن کمتر است. اسپ آسپرژیلوس، مونا سودومونا، انتر انتروباکتر، استش هم استاف 500 تومن کمتر است. Less than 500. Severe neutropenia germs. Severe neutropenia germs. Staph, Pseudomonas, Enterobacter, Aspergillosis. I think it is enough for we'll talk about gonorrhea and non-gonorrhea non-gonorrhea virusitis in a couple of minutes. Guys, was that a good introduction? Was that a good intro to antibiotics? I guess it was. I guess it was a good intro to antibiotics. It was a good eye-opener, I guess. So, Dr. Johnny, did you arrive home? Did you arrive home?